So it's a talk on genetics and male factor by Dr. Nisha Bhatnagar. Ma'am is a medical director at Avya Fertility and IVF Center, New Delhi, and also she's a director at Infinite Egg Freezing Center in New Delhi. She's a faculty, an esteemed faculty with us at ICEAT, and she also heads the infertility committee of the DGF West. So, ma'am has got a real interesting specialization in natural cycle IVF, minimal stimulation IVF, poor ovarian reserve, infertility management. She, of course, is a very respected member of so many committees and so many scientific groups, and very active with, guiding the youngsters, and also generally very interested and enthusiastic about teaching.
Thank you, Meenu. That's enough. I think we can start. And my presentation is genetics and male fertility. So I think we all know, let me just start my presentation. Give me a second, please. Yeah. So thank you, Meenu. Thank you for the nice introduction. And Meenu is herself a very intelligent and leading IVF specialist. So my talk
Thank you for
today
being
is,
so kind. Let's get started.
yeah,
Yes.
my talk today is genetics and male fertility. So my focus is more on identifying the males who need genetic testing. We see all kind of, semen analysis parameters in our practice, but I don't know how do we realize that which male needs a genetic testing. And that's what my focus is going to be on. So with the development of IVF techniques, we have seen a rapid expansion, and this has allowed, there is a lot of interest and investigation and research going on in the field of genetics in male and female fertility. There are the risk couples can take their informed decisions. They know what disease they are suffering from. They can take actions to prevent that. We have PGTA, we have PGTM, and then there are so many other things we can do. We can even do carrier matching and screening to identify if they both are carrying the same recessive or dominant gene. So my focus, leave all that apart, my focus today would be only on males who need genetic testing. So these are all the parameters of genetic evaluation, or infertility evaluation. And we would be focusing mainly on our point 8, that is genetic evaluation. We know that infertility affects a lot of people. 25 to 30% of couples have idiopathic infertility, and there is a genetic reason for in such cases. It may be caused due to cytogenetic abnormalities, it may be caused due to gene effects, or it may be sometimes because of epigenetic alterations. Why do we need to find a genetic cause of infertility? We know we want to find a cause and diagnosis relationship. We want to give the personalized therapy to the patient. We don't want the patient to have a genetically abnormal baby and then find it about it in amniocentesis or CVS. And we also want to know that what would be the recurrence in the next generation. For all these things, we need to find a genetic cause of infertility. So how do we know that there is a genetic cause for infertility? First of all, we need to take a detailed history. I remember from very beginning, in my time at least, we were told to take a very detailed history of the patient. From the history itself, we come to know a lot of problems the patient might be having or we might be suspecting. We need to know the age and, hello? We need to know the age and cause of death for the deceased relatives. We need to know the medications. Is there any prior genetic history? Anybody is on medications? Any specific disease they are suffering from? We need to know the pregnancies, the infertility history, how long they have been married, how long they have been trying. Are there any miscarriages? Are there any stillbirths? Any pregnancy complications? We need to know about the half siblings, if they are suffering from anything. We need to know the ethnic background of each parent and grandparent, and we also need to know if there is any consanguinity in the family, if they are married amongst the relatives and all. So for an infertile male, we need to know these targeted questions. First of all, the count, motility, and morphology. Not only one sample is sufficient. We need to analyze at least 3 to 4 samples. We need to see what is the general pattern there. We need to take samples, ideally 3 to 5 days of abstinence. At least 3 samples are needed to qualify that this is a azoospermic patient. And then we need to know, we can take the height of the patient, specifically 47XXY, Klinefelter, they are associated with the tall stature. We need to see and analyze the patient if there is any unusual appearance, if there is any small penis or testis, and there is a prior cryptorchidism history. We need to check if the patient has any learning disabilities, if they have any problem in smelling. I am sure that for infertility, we are usually not asking these questions. Do you have any problem in smell? But this is what is needed. We need to do the analysis of the patient in detail. If there are any nasal polyps, there is any history of chronic infection, asthma, or any sinus diseases, if there is any history of muscle weakness, if there is any history of early cataract, unusual birthmark, rashes, or scaling of skin, is there any bronze skin, and chronic disease. All these history we need to take. That will guide us whether we need to go for genetic testing for this infertile male. Now, there are targeted family history questions. We need to know if other family members are suffering from infertility, or is there any history of early menopause, the relatives who have had multiple miscarriages, any abnormal baby in the family. There are any, what is the general health of the family members? Are there any red flags? So what are these red flags? There are usually, we have to be lookout for red flags. These red flags are usually first and second degree relatives of suffering from the same or related condition. A common disorder with earlier onset than usual, especially if it is occurring in multiple family members. There is a sudden death history, 3 or more pregnancy losses, medical problem in children of parent who are closely related, or is a medical condition and dysmorphic features are present. These are the red flags. If we have any of these things in the couple or the partner, we need to look out for other things. So how do we identify the genetic family history? We need to know the genetic disorders and assess risk based on inheritance pattern. Look for recurring medical conditions and clues for a particular diagnosis. It is very, very important when we are suspecting that there is a genetic history behind it. We have to see the recurrence. Ask detailed history of the partner, the proband, the couple who has come to you, and their immediate relatives. See if there is inheritance of these systems, is there is some pattern they are linking there. Be aware of any red flags and look at the ethnicity, because some diseases are predominant in one particular ethnicity. So how do you start? You start with the proband, then you go to the half and full siblings, then you proceed from oldest to youngest children, siblings, uncles, and then aunts. Then collect names or initials, genders, and ages, and include ages of death. Ask about medical conditions and evaluations, and same conditions are more common in certain ethnicities. We already talked about this, and the consanguinity. So we already talked about these changes, which could be deletion, duplication, inversion, and translocations. Dr. Pallavi explained it very, very well. And now I would be moving on to specific male factor. So why we have so much of interest in genetics in male factor? Because sperm is very, very unique. Sperm is very, very interesting. There is always, they are in excess. There is a genetic uniqueness in each sperm. Their DNA is totally different. Each sperm would have a different, unique DNA. And spermatogenesis is a continuous process. It's not that you are born with all the eggs when you are born. Spermatogenesis is continuously going on. So the chances of chromosomal aberrations or anomalies is very, very high. Usually the lifespan of a spermatozoa is from puberty through life. It is 13 to 10 to the 6 per day. And there are there is continuous production of sperm going on. And they are transported from one part to another. So there is a very, very high chance that there may be a genetic mutation happening in these sperms. And our job is to look for that. So these are the reference values. And if we see, first of all, how do we suspect? Most of the times we are seeing infertile couple. And if we see any of these parameters in deficiency there, we need to check what are the causes. The causes may be sometimes only infection, the lifestyle, diabetes and all. And if you don't suspect any of these, if there is a severe oligoacidoteratospermia, the count is low, the motility is low, the morphology is low, or there is a azoospermia, then you should have this thing in your mind that you need to check for the genetic reasons. So this is an endocrinology of male fertility. normally, if you see a normal male, there would be a normal FSH and LH value, testosterone and prolactin would also be normal. In case of hypogonadotrophic hypogonadism, the FSH and LH would be low, the testosterone would be low, but the prolactin levels would be normal. In case of abnormal spermatogenesis, the FSH and LH would be high. There would be either high or normal, and the testosterone would be normal. The fourth subgroup, this hypergonadotrophic hypogonadism, this is what we are worried about when we think about genetic causes. Hypergonadotrophic hypogonadism, here you will find that FSH and LH would be high. The testosterone would be either normal or low. The prolactin would be normal. This is the subgroup we are worried about, and this is the subgroup which we should focus on genetic testing. Now, there is this Aphrodite criteria addressing male patients with hypogonadism and or infertility owing alternated idiopathic testicular function. This group 4, this is the new classification which has recently come, and this group 4 is the group of interest for us. If we see that there is a lowered semen parameters, including non-obstructive azoospermia, there is an elevated FSH level, normal or reduced testosterone level, then we say there is a functional hypogonadism, and we need to find out the reason for that. So there are the spectrum of male fertility, which is genetic related. Usually it can be an abnormal genotype in the somatic cells. For example, in Klinefelter syndrome, Klinefelter syndrome, XX male or Noonan syndrome. There are chromosomal abnormalities, aneuploidies or translocations. For example, Klinefelter, we have XXY. There is an extra X chromosome there. In case of monogenic and polygenic gene mutations, for example, CTFR gene mutation, cat sperm gene mutation, AR gene mutation, CAL1 genetic immotile ciliary syndrome, or there are deletions. For example, Y chromosome microdeletions. Then we talk about normal genotype in somatic cells. For example, it is 46XY, but there could be sperm chromosomal abnormalities, sperm DNA damage, sperm mitochondrial defects, or epigenetic abnormalities. This subgroup of normal genotype 46XY, usually it is related to either new mutations or the lifestyle of the patient. The patient may be living a very sedentary lifestyle, having a very high alcohol or smoking consumption, or they could be suffering from diseases like diabetes or something, where we see these chromosomal abnormalities, DNA damage, and mitochondrial defects. So understanding the genetics of fertility, again, we talked about Klinefelter. There are these two groups. Klinefelter, microscopic DNA, Y chromosome deletions and translocations, and then more single gene defects, X-linked, autosomal recessive, autosomal dominant, and mitochondrial causes have been identified. So Klinefelter, we all know it is XXY. We will talk about microscopic Y chromosome deletions in a bit. First, let's focus about these single gene causes of male inheritance. So select single gene causes of male infertility. We see X-linked. X-linked are androgen insensitivity, Coleman, Kennedy's, and X-linked ichthyosis. Then we have autosomal recessive, congenital bilateral absence of VOS difference. This is basically seen with cystic fibrosis, Kartnager syndrome, sickle cell disease, and hemochromatosis. Then we have autosomal dominant myotonic dystrophy and Noonan syndrome with cryptorchidism. So whenever we see the first indication to try to identify this and put them in a single group is the severe oligosteroteratospermia or azoospermia. So when we talked about Y-linked inheritance, again, Dr. Pallavi told you in detail, the males will only pass to their male and their sons. All sons of a male with a Y-linked condition will be affected and will pass on conditions to the sons. It is very, very important because the couple need to know that not only they are affected by this will be passed on to their children and the children's of their children. So no daughters will be affected if it is a Y-linked inheritance. Now, this is Y chromosome microdeletion. We all know that there is a P arm, there is a Q arm, and there are three reasons where this is affected. TZA, TZF alpha B, TZF alpha C. Why this is important to know? Because we know that if it is TZF alpha C, which is affected, the Y chromosome part of TZ alpha C is deleted, then the prognosis is good. There is a probability that you will be retrieving sperms with micro TC, and there is a chance that couple may have a child of their own. However, if the deletions are present in A and B, the prognosis is not good. The chance of retrieving sperms, even with micro TC, is very, very less, and it will be passed on to the children. Now, moving on to cystic fibrosis, we know that this is caused by a cystic fibrosis transmembrane conductance regulator gene, and it is an autosomal recessive inheritance. Cystic fibrosis is caused by mutation in this particular gene. There is a distinct function of chloride channels, and cells produce thick mucus. So this is the ASCOG committee now suggests that we should offer cystic fibrosis screening pre-conception or early in pregnancy to all women regardless of ethnicity. It can be sequential or concurrent. However, genetic counseling should be offered when there is a family history of cystic fibrosis to both the partners when both partners are carriers. However, we see that there is a large predominance of this in the Western world. We still see very less cases of cystic fibrosis here. This is a small paper where they saw that there is a carrier risk after negative result. Now, to cut it short, the classification of genetic causes of male infertility, we know there could be chromosome aberrations, for example, Klinefelter, YY aneuploidies, 47XYY. Then there are structural Y chromosome aberrations, which could be deletions, ring, isochromosomes, inversions, translocations. Then we see problems in autosomes like translocations, Robertsonian or reciprocal translocations, inversions, and the most important part for us is Y-linked microdeletions. We see very common this Y chromosome microdeletions, and the patient are anxious to know whether they will be able to have some kind of, retrieval of sperm even after doing micro TC. So you need to know that Y chromosome microdeletions are present in which part, A, B, or C, and you can give hope to the patient accordingly. So there are rare cases of male infertility. I just put it where we see it very rarely, the mitotic dystrophies, Noonans, and all that. So these are the genetic tests which we are offering. I think this chart is very, very important for all the clinicians, because this chart tells us that what should we do in cases of azoospermia. You should offer that during diagnostic workup only, prior to going for ART. You should offer this karyotype, and you should offer the patient about going for a genetic, not only karyotype, Y chromosome microdeletion also. In case of severe oligospermia, you can offer during the diagnostic workup. If there are microdeletions, you can offer during diagnostic workup. And CFTR gene mutation, again, bilateral absence, you should offer prior to ART. I think we should have a picture of this. Now, how to prepare the couple? Explain what you are doing. What is the reason why you are doing it? Explain what you are looking for. Encourage the patient to mention anything that comes to their mind. If there is any additional information, there is a pre-session family history questionnaire which they should fill, and maybe if needed, genetic consultation should be done. So the take-home messages: perfect males exist only by this is a statue of King David made by Michelangelo. It's a statue of a perfect male. There is a history stating that when Michelangelo was making it, and he was at the end of it, he was so obsessed that he broke his hammer, saying that, why don't you speak? Perfect males exist only in the Michelangelo statues. You should consult nowadays in infertility era. If there is a azoospermic male, you should be clinically evaluated to differentiate genital tract obstruction from impaired sperm production, initially based on semen volume, physical exam, and FSH levels. If the FSH levels are very high and the physical examination states everything, but still azoospermia is there, karyotype and Y chromosome microdeletion analysis should be recommended for men with primary infertility and azoospermia. In case of severe oligospermia and elevated FSH or testicular atrophy, you should go for a genetic testing and analysis by a genetist. Thank you from my side. If you have any questions, I would be happy to answer after the session.
Ma'am,
I
wonderful
hope I am
presentation,
on time, Dr. Meenu.
Absolutely bang on time, ma'am, and a wonderful presentation, so concise and loaded with info. So I think the audience should have taken a lot of notes and pictures here. So thank you so much, ma'am. And any questions maybe the audience has, you could ask us, or else we move on to the next topic for the day.
One question again, Dr. Preeti here from Chandigarh. So what if a patient comes with OAT syndrome or severe oligohydramnios? So
Yeah.
what test so I think because for the gene locations, we cannot do a karyotype. That will not
No.
tell us much.
See,
So what one test we can do for them?
So, Dr. Preeti, I think the first thing we need to do in cases of severe oligohydramnios, you need to find out that where is the problem. So, first of
Correct.
all, you do the FSH, LH, and testosterone levels. If you see that FSH, LH levels are very high, and those cases you see that there might be some kind of testicular failure, and you need to identify the genetic reasons. Then you go for
Correct.
karyotype and Y chromosome microdeletion. These are the two tests you need. Y chromosome microdeletion and karyotype.
Okay. Thank you. Thank you. Okay. Just one more thing, sorry. What is the role of gene sequencing over here? Whole exome gene sequencing. Because many times we do the karyotype, we send to the geneticist, and then they say, now go for the whole genome sequencing or whatever these advanced tests. So, can't we go for them straight on?
No. Straight on, you should not. If you have if there is, first of all, there is a stepwise process. Whole exome sequences it is advised only if you are suspecting some single gene disorders. You see, there was a classification in case of single gene disorder, in case of, if you have some kind of aneuploidies, you will get with karyotype. If you have Y chromosome microdeletions, then you do with Y chromosome microdeletion. Only if you are suspecting some single gene disorders, then for example, cystic fibrosis, then you go for telling the patient to go for whole exome sequencing. I don't suggest whole exome sequencing. And for suggesting whole exome sequencing, I think the genetist should be in loop.
And we should always
genetists
follow an
are in the
algorithm.
loop. Yeah.
Always follow
that
an
is fine.
algorithm.
Yeah, we follow the algorithm. I'm talking on the step 2 only. After basic hormonal test, and when we reach to some diagnosis that, okay, the karyotype, usually the karyotypes are normal in these cases.
Yeah.
So,
If the karyotype is
that's fine.
normal, you need to go for Y chromosome microdeletion. If Y chromosome microdeletion is also normal, you need to look for other reasons. Sometimes, as I already said, in case of severe OATS, it may be the lifestyle, it may be the diabetes, it may be the, sedentary lifestyle or too much of smoking or drinking. So you need to analyze with the hormonal parameters that what is the problem.
Right. Okay. Thank you.